Okay, everyone, we're going to get started. And here we go. So disclaimer, this webinar is just for educational purposes only. It's not medical advice, and we recommend you consult with your healthcare provider about individual circumstances. And also the statements in this webinar have not been evaluated or approved by the FDA. Okay, so I want to start today with a patient in particular, not because, this patient in particular has, it's not a gastric cancer talk, right? But this case fits perfectly because of, it illustrates really how um, it develops. And my patient is a reluctant 61-year-old man who underwent an upper endoscopy, so upper GI tract, for chronic GI symptoms. And he's been following a gastroenterologist for some time. And this time the biopsy showed that he had gastric metaplasia. So importantly, he doesn't have cancer, right? He has changes that are going down the pathway of cancer. So this patient in particular is not a big believer in regenerative therapies or really anything outside of conventional medicine. But when what the gastroenterologist said next, sent him over to me and what we do in my clinic, hoping for a better answer. So what was it that the gastroenterologist said? He said, come back in 3 years. Okay, so he explained the findings to him, right? And he said, we'll repeat the endoscopy, we'll get it done in 3 years, and we'll see. We'll wait and see if this turns into cancer, then we'll do something at that point. Now, that recommendation is very common. It's very guideline based, and on paper, it does make sense, right? But when he came to see me, he asked a very reasonable question, which was, what happens in 3 years or, during those 3 years? And, maybe you can imagine the health anxiety that this person feels and what that would cause for somebody to wait for 3 years. And you'll put it into the back of your mind. But as that time point gets closer and closer and closer, the anxiety is going to increase and increase and increase. And that's certainly not going to help metaplasia. No, any kind of stress like that can really contribute to health outcomes. So for 3 years, you wait and see if something actually changes or if the changes are taking place that will cause cancer. And then what? At that point, if there are cancer, will you remove the stomach? And if we know that there are changes actively occurring right at this moment, then there has to be something that we can do now to stop that progression, right? So that was the question. That question is really the driving force for this type of webinar and the reason for this entire talk, because gastric metaplasia, and this is not, I'm not just talking about gastric metaplasia, but this frames what I want to talk about. But gastric metaplasia, it's not cancer. It's also not nothing. And by that, I mean, there is a visible histological sign that the cells have changed identity in response to chronic stress. And that's why it makes it such a powerful teaching model, because for once, we're not looking backwards at cancer and guessing how it started. We're looking forward at a biological system that is actively adapting at this moment. So this is the moment where cancer biology is still plastic. There's still something that can be done, right? So instead of saying, will he get cancer? I want to ask a different question, which is, how can we stop it from progressing to cancer? And you could take this from any metaplasia, dysplasia, that kind of thing. And how do we get to this point to begin with? And by asking these questions, you stop trying to figure out what is different about all the different cancers. There's lots and lots of different types of cancers. But you start asking a question like, well, what do they all have in common? Because there is common ground. And what must already be true for cells to get to the point that they get to? So now to understand that question and why that matters, we have to zoom out a little bit. So, cancer certainly is not a rare disease. It's becoming one of the dominant chronic health challenges of our time. And globally, we're now seeing over 20 million new cases per year, and projections suggest that that number will rise more than 70% by 2050. So, not that far down the road. In the United States alone, over 2 million new diagnoses are expected this year coming up. And that's not just a more people issue. It's a significant increase. And so while survival rates have improved, largely due to better detection and better treatment, there's another side of this story that doesn't get discussed enough. And we now have millions of cancer survivors, which is great. That's a success story in and of itself, but it also creates a new challenge. Because remission does not mean that the underlying biology has been corrected. And recurrence rates vary dramatically based on that tissue type. So some cancers recur early, right? So, maybe you see a recurrence within a couple of years, but some recur late, maybe 10, 20 years later. And we don't hear about those cases because longitudinal studies don't usually follow the patients that far out. There are some that retrospectively are looking at that, but the endpoints for a clinical trial generally are 1 to 5 years. And so hormone-positive breast cancer is a classic example of a late recurrence. Prostate cancer commonly shows biochemical recurrence years after treatment. Colorectal cancer is another big one, and it has when you have so colorectal cancer, the recurrence rate on that depends heavily on your stage and metabolic context for sure. But some cancers change their strategy and adopt the signaling of a different type of tissue, right? So it depends on where it starts. So it's going to pick up the characteristics of the tissue that it's already in. So in breast cancer tissue, it can adopt the signaling capabilities of growth. So estrogen in breast tissue is a growth hormone. It's encouraging. It's a growth signal. So that's why you see stuff like that signaling. But if you stop estrogen, and that's part of the course of therapy for breast cancer, then the cancer takes a step back, right? And if you don't change that terrain, it changes course, and it can take on a signaling capability of a different tissue type based on what the body's trying to do, right? So for instance, a breast cancer survivor is 10 times more likely to not just develop a breast cancer recurrence, but a second primary cancer such as lung cancer or colorectal cancer. And maybe somebody that has survived breast cancer. And then you hear 5 to 10 years later, oh, she now has a new cancer. And you think, oh gosh, that poor woman, what are the chances of her getting 2 separate cancers like that? And it's actually, fairly high, higher than you might think. So the pattern is not random and it's not bad luck. It reflects a shared biology, a shared exposures, and shared treatment effects. So this tells us something important about cancer, because cancer treatments can remove diseases, and I'm not anti-cancer treatments by any stretch of the imagination, but it does not restore health, and that's what we really want to look at. So let's look at the conventional pathway and its limits. And like I said, I want to be very clear here because conventional oncology is incredibly good at what it does and what it's designed to do. Okay, so it detects tumors, it stages diseases, and it irradiates poisons or blocks growth pathways, whatever it needs to do. And for many people, it saves lives. So there's no approved drug to reverse metaplasia. And in pre-malignant conditions like gastric metaplasia, the logic's also sound. There's no tumor to target, so there's no approved drug to reverse it. So the system does what it knows how to do best, which is it watches, it observes, and that's fine from a guideline standpoint. That's a reasonable expectation. But here's the problem, because your biology doesn't pause while we observe in a hopeful silence. So what is happening in our watch and wait? When we tell somebody to come back in 3 years, what we're really saying is We're not intervening at that biological level, but the cells are still responding to the environment that they're in every single day. So they're sensing nutrients, they're sensing inflammation, they're sensing oxidative stress, they are sensing immune signals. So the metaplasia tells us that the environment has already pushed cells into a survival phenotype. And cells don't change identity unless the signals telling them who they are to become is unreliable. This isn't a mutation, it's actually an adaptation. And adaptations are reversible if you understand what's driving it. So here's the real question. If we know that cancer doesn't appear overnight, it's not something that attacks you as you're walking down the street. It's something that occurs in the body, usually due to some lack or deficiency of something. So if we know that pre-malignant states represent a biological drift, and we know that recurrence is common even after successful treatments, then why is our only strategy just to wait? What if cancer risk isn't just about finding tumors early, but about correcting the conditions that make the tumors possible in the first place? And that's where terrain comes in. So before we go any further, I just want to introduce myself. I'm Dr. Katie Harris. I'm the owner of Philly Wellness Center in Philadelphia, and I've been a practicing nurse practitioner for the last 25 years. My background is in neurosurgery, neurocritical care, and I've been a first assessed in brain and spine surgeries for over a decade. So I transitioned into functional medicine during the pandemic, mostly for self-serving purposes and health conditions that I was dealing with. But this journey has taken me down a rabbit hole that, one, I wasn't expecting, but I wasn't happy with the treatments that for my symptoms, because my goal, like many of you, wasn't to cover them up or just to blunt them. I wanted to understand why they were occurring in the first place. And this kind of makes you a bad or difficult patient in a lot of ways, because people don't necessarily have that luxury of taking time out to explain all this stuff to you, because your visits are very quick. They're 5-10 minutes. You have to move through the system very quickly. So I wanted to understand what was happening and why these symptoms were occurring. Even though you'll be told we don't know sometimes or why this is happening, the truth is we do know quite a lot. And the problem here is that there's a huge disconnect between clinical medicine and biochemistry. And that was the path that I got led down. And what I found was that clinical medicine seems to operate outside of the logic and research of biochemistry for a variety of reasons, both known and unknown. But it's down this rabbit hole that I first learned about phospholipids called plasmalogens, which is a critical phospholipid in the body. It has powerful predictive capabilities. But the question was, well, I've never heard of these things before, right? Like, how can something so vital, and they are very vital. Basically, when you run out of plasmalogens, you die. So if this molecule is so important, how is it that no one that I know in the medical community and myself has ever heard of them? Well, biochemistry has been researching them for almost a century, not a decade, almost a century. They've known about them for a very, very long time, but no one ever bridged their importance over to clinical medicine. And plasmalogens play a huge role in cancer. So I do want to get back to the lecture, but I also want to be upfront here. I'm not a biochemist. I am not an oncologist, and I'm not here to convince you of anything, basically. I'm not pro or anti chemotherapy. I am pro cell membrane and taking risks that restore membrane health. And that's it. So what you choose to do to mitigate risk, cancer risk, how you decide to treat cancer, how you want to restore health is a personal journey for you. So what I want to add here is that what we're doing is empowering you with information based entirely in biochemistry. And that has not made its way to mainstream clinical medicine. So this is stuff that you won't hear or see anywhere else. So I cannot offer large randomized double-blind studies because you need multi-million dollars, $50 million to do something like that. And that's Big Pharma runs those. But what I can do is offer you a biological perspective that's based in chemistry and physics of how the body is supposed to work and what happens when it starts to do a workaround. So let's go over some of our teaching points that we're going to talk about. So when you strip cancer down to its fundamentals, three things have to break down for it to take hold. So regardless of tissue type, whether it's stomach, breast, colon, prostate, the pattern's the same. Okay, so first, the cells lose their identity. And I know you're probably like, what does that mean? So we'll talk about that. But cells also lose metabolic purpose and they lose supervision. So in the second half of this talk, I'm going to talk about each one of those, but not as theory, but as clinical logic. Okay. And I'll keep coming back to, my patient with gastric metaplasia, because his case shows us exactly where intervention makes sense. We're not talking about treating cancer. What we're talking about is preventing biology from needing cancer as a solution, because that is ultimately what cancer is. Cancer is a solution when no other solution is viable for the body, because that's what cancer is at the root of it. Okay, it's a biochemical failure of the cell to support itself. So cancer doesn't invent new biology. It overuses existing biology in an environment that's lost its checks and balances and identity cues. So let's talk about what those cues really are. All right, so first one, the first major breakdown that allows cancer to emerge is the loss of cellular identity. And this doesn't begin in the nucleus, it begins at the cell membrane. So the cell membrane, we'll talk about this in a little bit, but the cell membrane is pretty much the house. It's like, you think about the house that you live in, it's made with bricks and mortar, right? So the cell's house is the cell membrane, and that's going to be important. So cells decide at the level of the cell membrane what they are and how they respond to their environment through membrane signaling. So the membrane has to receive signals in order to know what to do. And if you distort that membrane, then you distort the decision-making process of the cell. Now, when I say cellular identity, I don't mean genetics. We're not talking about genetics at all. I mean something much more practical. So a stomach cell knows that it's a stomach cell because it receives consistent and coherent signals telling it how to behave. Just like a random example, just like a princess knows that she's a princess because she's told every day. She gets these signals all day long. They're coherent signals. You're a princess, you have to act this way, you have to do this. And she's not genetically programmed out of the womb. She doesn't know these things, because being a princess is a contextual construct, right? And cancer, as you will see, is going to be a contextual construct as well, not a genetic one per se. So, for example, let's take Meghan Markle for an example. She became a princess by association. Her genes had absolutely nothing to do with it. And we tend to have this obsession with, oh, it's in my genes. This is going to happen to me because it's in my genes. It happened to this family member and this family member and this family member and this family member. Well, is it the genes, or is it that you just adopted the same lifestyle that they adopted, right? Because after trillions of dollars spent on genetic research, the genes haven't accounted for much more than 10% of disease overall, not just cancer, but in overall. So that means 90% is context. That's a huge difference. So anyway, back to the analogy, Meghan received constant signals that she was indeed a princess, right? Until one day her identity changed and she chose to no longer be a princess. Again, her genes didn't change. Her genes stayed the same. They have nothing to do with it. Her context changed, and identifying as a princess was no longer something that she chose to do. She wanted to save herself in other ways. So I'm not here to get into a discussion on the pros and cons of royal living, but it is a great way to explain cell behavior. The cells work in their own best interest in the short run, and oftentimes to the detriment of your overall health long term. And they don't do this because they're evil and mean. They do it because they're desperate to perform their job or simply just to survive. So let's go back to gastric metaplasia for a second. What's actually going on here? And this is a good example of where cells are losing their identity. So why would a stomach cell choose another identity and start to change? Why does it want to change? Because that's what metaplasia really means, right? The cells are changing shape and form. So why would they do that? And they're doing it to survive, because the context that they're living in is not survivable, okay? And in this particular case, the problem in a nutshell is, in this case particular, was long-term exposure to H. pylori, which the inflammation can cause the muscle that's called the pylorus between the stomach and the intestine to not close fully, right? So then you get bile regurgitation into the stomach. Well, what's bile? Bile salts are literally like a detergent, right? And the stomach is not designed to deal with detergent. Stomach acid has a very, very important function of breaking down our food so that we can utilize glucose and amino acids in our everyday functioning. So the stomach cells are designed to live in harmony with acid. Now, the rest of your body can't do that, right? Like if you had acid in your stomach, in your intestine, you'd get an ulcer, right? So the stomach acid and the stomach cells have synergy. They can work together very well. Now, when bile regurgitates into the stomach, because that pylorus is not completely closed, it can happen for a variety of reasons. But that repeated injury forces the stomach to adapt to an environment, and that is the start of metaplasia, because if now instead of dealing with stomach acid, the stomach has to deal with bile salts, it needs to adapt so it can deal with those bile salts. And we've seen this throughout history, right? Just to give another analogy, everyday analogy. So, when people are placed in an environment that they're not designed for, they adapt to it, right? Like if you move from Florida to Alaska, if you wear shorts, you're going to freeze in the winter, right? You got to adapt to living in Alaska. During the war, farmers became soldiers, right? And women went to work during World War II. And during COVID, we stopped working in the office. We went home and we started working from home. So that adaptation might happen rapidly, which is usually the case, or it can happen over repeated exposures for a length of time. But once it's entrenched, it's actually hard to reverse. So, farmers might come home and maybe they liked being a soldier, or maybe they found that their land was mismanaged and now they can't be a farmer anymore. And women after World War II didn't want to go back home. They wanted to continue working. And even, COVID, like who wanted to go back to the office after spending 2 years at home? It was very hard to transition back to the way it was. And that adaptation can be very difficult to reverse. It requires significant and consistent terrain improvements. And if the cells don't have the resources to do the jobs that they were set out to do, so the stomach needs to help digest proteins and glucose, they have to start stealing resources from other cells, and they can go into conservation mode. We call it conservation mode, and they start their own kind of covert operations to get the job done, a workaround. We do this as nurses all the time. Like when they put confines on us, or we have to work with 3 fewer nurses than we're supposed to, we start doing workarounds, right? And, you might not like it, but we can't get the job done if we do it the way that we're supposed to do it. So when you're 3 people down, you do it the way that gets the job done, not necessarily the way that's laid out in the handbook that you're supposed to do it. And the cell they'll do the same thing. So cell behavior and human behavior are very similar. Like our cells do what humans do, or humans do what our cells do. So, I guess the cell came first in this case. But now let's go back to the signals for a second. Where do those signals come from? Who's sending out these signals? So the signals come from the receptors on that cell membrane. They live inside the cell membrane. And that's what, the cell membrane, again, is the house that the cell is living in. And the cell membrane is that it's a house for every cell. So like I said, your house might be made of bricks and mortar, but the cell's house is made up of phosphatidylcholine, cholesterol, and plasmalogens and fatty acids. That's what you see here, this circle around here, that's what this is. So phosphatidylcholine, fatty acids, these little tails, cholesterol is holding this shape together, so it's really important. And plasmalogens are kind of hanging out here and protecting the cell from invaders and attacking. So it's not a passive barrier. Your bricks and mortar of your house are passive, right? They're not there to protect you. But in the cell membrane, that's not the case at all. It's an active signaling platform. And it determines which signals are received, which are ignored, which are amplified, and which are distorted. So identity is not just coded, it's actually interpreted. So when membrane integrity is compromised, three things happen. One, your receptor signaling becomes noisy. Okay. Two, your growth and stress pathways activate inappropriately. Three, cells are going to start shifting towards survival type behaviors. So this is not cancer yet. This is adaptation. Okay. Cells don't suddenly decide to become malignant. They decide to survive. And survival phenotypes are less differentiated by nature. So metaplasia is the clearest example of this process. A stomach cell under stress says, I can't function here normally, so I'm going to become something more resistant. That is identity loss, and that's what we're talking about. So, and here's why this matters for cancer. So highly differentiated cells are stable. They have clear roles, they have tight control, they have strong checkpoints. Survival phenotypes are the absolute opposite. They are less specialized, they're more flexible, more tolerant of stress, but that flexibility has only short-term vitality and use. Long-term, it's going to increase replication errors, signaling drift, sensitivity to oncogenic pressures. And so metaplasia isn't cancer, but it's risk enabling. It's a risk enabling state. So, and that brings me to one of the most common and understandable mistakes that I see in cancer prevention and survivorship care. So the cells are the very components that they need to maintain identity. I've had a lot of my cancer patients tell me they were told not to have choline whatsoever, right? Well, phosphatidylcholine is one of the building blocks of your cell membrane. Or lower your cholesterol. Well, cholesterol is the structural building blocks of all of your cell membranes. Or stop eating saturated fat. Well, half your cells are made up of saturated fat. So, and that is, that sounds reasonable, right? But, and especially if cancer is using these, right? So cancer is reallocating the very building blocks that we use. So, maybe we should just, not eat choline and lower the cholesterol and all that kind of stuff. So because cancer uses those things, right? So the idea is let's restrict them. But here's the problem with that. Cancer doesn't exploit abundance. It exploits dysfunction, first and foremost. So when your membranes are under-resourced or oxidatively damaged, the receptors will misfire, your growth signals become distorted, cells will lean harder into survival programs. So that doesn't protect against cancer. It actually worsens identity loss because now you have more cells, have more problems. So what we can learn here is what cancer does to build its own army. Cancer does not introduce new building blocks. It reallocates existing ones, except it uses them faster without regulation and redirects them towards uncontrolled growth and survival instead of function. So it's wasting all of your resources that you have. So the core building blocks for both cancer and normal cells are amino acids, right? I mean, cancer uses large amounts of amino acids like glutamine, glycine, methionine. Cancer is protein hungry, not because protein causes cancer, but because growth requires structure. So you're not going to eliminate all amino acids from the body. That would be crazy. So lipids, cancer needs to continuously build new membranes. So it needs phosphatidylcholine, cholesterol, which will provide membrane stability, right? That's how it works in normal cells, and that's what cancer is trying to replicate. And it also needs saturated fats. So it'll hijack your body's ability to make these fats and various systems that you have and removes the control lever. And that's the key, right? When you remove the control lever and you're on, you're just churning things out night and day, that is the problem. That's the check and balance that needs to be fixed. So, and then cancer doesn't like omega-6, and we're going to talk a little bit about omega-6, but mostly because it makes the membranes unstable, which is a good lesson to learn from cancer. Glucose is the carbon backbone. So cancer uses glucose because it's fast and flexible, right? And it's practically unlimited because the body can make as much as it wants. Cancer can turn on gluconeogenesis and locally support itself. Nucleotides are needed to replicate. So cancer needs purines and ribose and nitrogen from breakdown of protein. So that replication stress is central to cancer. That's why anything that increases DNA damage without repair, the repair capacity increases risk. And a surprising example of that would be linoleic acid, which is omega-6. So that toxic byproduct of linoleic acid is actually aldehydes, and aldehydes do damage DNA. So if you're burning omega-6 in the body, it's releasing these aldehydes. But the body is smart, and it doesn't burn omega-6. But what it does is it jam packs it into the cell membrane, and that causes other problems. But now, omega-6 is an essential fatty acid, and it's not to be eliminated completely from the diet, but excess omega-6, especially in the form of seed oils, fried foods. I've done a lot of videos on omega-6, and prepackaged foods, especially anything that's sitting on a shelf and can last for weeks on end, has seed oils in it, because that's the only way that it doesn't go moldy. But all of that stuff is creating a huge volume of omega-6 that we were never designed to consume. And it's a huge insult to our bodies. So cholesterol, the cancer uses cholesterol to stabilize membrane, amplify growth, and build lipid rafts. So cancer doesn't thrive on systemic cholesterol abundance. So lowering cholesterol only hurts normal cells because normal cells need cholesterol to build their own cell membranes. Cancer thrives on local membrane dysfunction and signaling imbalance. So iron is context dependent. It's kind of a double-edged sword for cancer. Iron is used for DNA synthesis and rapid proliferation, but too much iron can kill cancer. So cancer must tightly regulate it. So it's called ferroptosis, and it's a technique that's used in some cancers that we'll talk about at the end. So bottom line, cancer uses materials for survival and replication instead of for function. It creates its own signals, prioritizes growth and trade specialization for speed. And it's not different because of what it uses. It's different because it uses everything without restraint. And that's a big piece of this. So depriving membranes doesn't starve cancer, it destabilizes normal cells. So you don't beat cancer by removing building blocks. You beat it by restoring the rules that govern how those blocks are used. So let's talk briefly about omega-6, because this is where a lot of confusion comes in. Linoleic acid is not evil, right? You need it, but it is highly prone to oxidation. So an excessive omega-6 burden, especially in a system that's already under oxidative stress, leads to lipid peroxidation, which is the cell being attacked by different toxins and oxidative stress, membrane instability, toxic byproducts like 4-HNE, which comes from linoleic acid breakdown. And those byproducts don't just damage membranes, they distort signaling, and distorted signaling pushes the cell into survival mode. This is why the goal is not membrane deprivation. The goal needs to be membrane repair and signal fidelity. So the brain frame here is cancer cells and healthy cells use many of the same materials. The difference is not what they use. The difference is how well the system regulates their use. And healthy cells with intact membranes receive accurate signals, maintain differentiation, and respond proportionally. Cells with damaged membranes over-respond to stress, misinterpret growth cues, and drift towards survival identity. So our job, especially in pre-malignant states and remission, is not to starve cells, it's to restore their ability to listen correctly. And from a clinical standpoint, that means supporting phospholipid availability, reducing oxidative burden, protecting membrane structure, and avoiding unnecessary deprivation strategies. So we're not targeting tumors, we're trying to stabilize biology. So, loss of identity alone isn't enough. So the next thing that we're going to talk about, cells need energy to sustain that identity. So when mitochondria fail, cells don't just slow down, they change their strategy. And that brings us to the second teaching point, which is the loss of metabolic purpose. So once cellular identity begins to erode, the next system to break down is metabolic purpose. And cells don't just need to know who they are, they need to know how to generate energy efficiently. And in order to remain that thing that they are, and that job belongs to the mitochondria. So what do the mitochondria do? So we often describe them as powerhouses, right? I say that a lot in my videos, but that's not, it's an incomplete statement, right? Mitochondria don't just make ATP. They coordinate fuel selection. They signal cellular sufficiency. They regulate stress responses, and they enforce differentiation, which we know is very important for healthy cells. So in other words, mitochondria tell a cell whether it can afford to specialize or whether it needs to just simply survive. So when mitochondria are healthy, cells can maintain long-term roles. When mitochondria are stressed or inefficient, the cells are going to pivot. And when mitochondria efficiency drops, cells, they face a problem, right? So you have oxidative metabolism is slow. Normal oxidative metabolism is slow, precise, and efficient, but it requires stability. Under chronic stress, the cells want things done fast, right? So they go for less efficient energy strategies. And that's where you see things like increased glycolysis. And what is this stuff? You don't have to remember these words, but increased glycolysis, reduced oxidative phosphorylation, a preference for short-term ATP or energy over long-term efficiency, right? So it adapts to this quick fix. And this shift is called the Warburg effect. So you may have heard of something like that, but it's better understood as a stress metabolism. It's not a cancer trick. It's actually a survival response. The cell is trying to survive. It's not getting what it needs from the mitochondria, so it takes matters into its own hands and starts producing its own energy and its own function. It turns off the safeguards that the cell has, because if you have a leader in the plant and nothing is getting done, the people might be like, well, you know what, we're gonna take matters into our own hand, and that's what the cells are essentially doing here. Oh, and we've seen it throughout history. So in stable societies, people plan, build, and specialize. And when there's famine, war, collapse, people don't stop being human, but their priorities change, right? So long-term investments are abandoned. You're not going to be like, oh, what am I doing in 15 years? You're like, no, what am I doing today? Like, how am I going to get through today? So survival becomes the goal, and the cells will act in that same way. Now, one of the most important consequences of mitochondrial dysfunction is pseudohypoxia. And this is where cells behave as if oxygen is limited, even when it's not. So why does this matter? Because hypoxia starts signaling. It pushes more cheap and easy energy and activates growth and stress pathways. It weakens the cues to differentiate. So even without a tumor, even without mutation, cells begin to behave as though they were under existential threat. And that fertile ground is for cancer biology. And so why this increases risk? Cells that rely on stress metabolism replicate under pressure. They generate more metabolic byproducts. They accumulate more signaling errors, and this increases epigenetic instability and replication stress. So again, this isn't cancer yet, but it's selection, right? The cells that can tolerate chaos are going to survive, and cells that require order are going to start dying, and then you're going to see a transition over. So cancer is very, very good at tolerating chaos. It loves it. And this brings us to another common misunderstanding, that if cancers rely on glycolysis, which is basically how you manage carbohydrates or glucose, right? If cancers rely on glycolysis, then the instinct is to remove glucose, fasting, carb restriction, metabolic stress. And these tools absolutely can be useful, but in the right context. So here's the point. Cancer doesn't just rely on glucose because it's fragile. It relies on glucose because it's flexible. So cancer cells can also recycle lactate. They can use amino acids. They can generate glucose intermediates internally. So they can shift fuels when they need to shift fuels. So that's why fasting helps, right before chemotherapy. If you're doing chemotherapy, but it's not a strategy that I would rely on solely. If I had a cancer diagnosis, I wouldn't be like, oh, I'm just going to fast and then I'll starve cancer. Like that's not an adequate strategy, because the cancer cells can get resources from other places. So glucose is not the only feeding mechanism. There's lots of things that they can do. Normal cells with impaired mitochondria cannot do what cancer does as well. So if we never restore mitochondrial health, we widen that gap between cancer cells and normal cells. So starving fuel without restoring function selects for the most adaptable cells. And in that case, that could be your cancer cells. Now, this is why recurrence risk persists even after successful cancer treatment. So tumors can be removed, right? But if the surrounding biology doesn't change, if nothing's changed, then that biology is still favoring metabolism. So you have to think about that for a second, right? So there was a biology that existed before the cancer emerged. You remove the cancer, but the environment's still the same. And I always think of, sadly, Afghanistan, right? Like, we go in and get rid of the Taliban out of Afghanistan, and 20 years later, they're back, right? Like, but all of this stuff happened in between, right? There was war, there's this, all these things happen. And it's the same in cancer biology. So the things that led up to the stomach dysplasia, right? In this case, with gastric metaplasia, if you remove the stomach, then that would clear out the cancer, right? Like ideally, because then, I don't know where the bile wouldn't be able to backflow into the stomach. They would bypass the stomach completely and do a gastrectomy, but that's going to cause a whole nother slew of problems. But in breast cancer or prostate cancer, pancreatic cancer, that cancer still went through the same process of changing because the environment was permissive and allowed that to happen. And just removing the tumor that forms isn't enough, right? You have to change the terrain so that it is inhospitable to cancer growth. So the goal isn't to push cells harder. It's really, the goal is to help the cells to return to efficient, confident energy production. And when the mitochondria are restored, cells tolerate stress better, growth signals quiet down, and differentiation becomes more sustainable again. So it's not exactly about maximizing more ATP, it's about restoring that metabolic purpose. And our last teaching point is about the immune system, right? So loss of immune surveillance. So we've talked about the two major failures that precede cancer. First, your cells lose identity. Second, they lose metabolic purpose. But neither one of those guarantees cancer. None of this guarantees cancer. It's just the terrain is permissive to cancer occurring. So the final failure, the one that allows abnormal cells to persist, is the loss of supervision. And the supervision comes from your immune system. So when most people hear the immune system, they think, oh, you're my defense system, fighting infections, killing invaders, all that kind of good stuff. But one of the immune system's most important role has nothing to do with infection. It's pattern recognition. So a healthy immune system surveillance constantly scans tissues for cells that don't belong, that are they're not behaving normally, right? They're not following the rules. So this happens quietly, continuously, and without inflammation when things are working properly. Most abnormal cells they're removed long before they become clinically relevant. That's really important. The immune system is very important for that. So the immune system doesn't primarily prevent cancer by attacking tumors. It's not what it does. It prevents cancer by removing abnormal cells early. And by the time the tumor exists, surveillance has already long failed. Cancer was able to evade the surveillance system in play. So when we talk about immune support in cancer prevention or remission, we're not trying to boost immunity. We are trying to restore recognition and response fidelity. So think about supervision in basically any system. In a workplace, problems don't escalate because rules don't exist. They escalate when oversight disappears, and cells behave in that same way. Immune surveillance doesn't fail randomly either. It fails under predictable conditions: chronic inflammation, metabolic stress, oxidative overload, hormonal dysregulation, and repeated tissue injury. These conditions don't just stress cells, they also exhaust immune pattern recognition. The signals become noisy, abnormal cells stop standing out, and once abnormal behavior becomes common, it stops being recognized as abnormal. And this is where a lot of well-meaning approaches can go wrong, right? So when people hear immune system, they think, oh, stronger is better, so let's stimulate. But stimulate is not supervision. In fact, excessive immune activation can increase inflammatory signaling, it can promote tissue damage, it can create more noise and not clarity. So cancer doesn't thrive because the immune system is weak, it thrives because recognition has failed. An immune system that's always yelling has trouble hearing whispers, right? So if it's always constantly responding to inflammatory issues, it might not hear the more subtle or see the more subtle patterns. And one of the most overlooked aspects of immune health is basically education. What education, right? The thymus is where the immune cells learn what belongs, what doesn't belong, and how to respond appropriately. So as we age, and especially under chronic stress, that educational process declines. Your T cells become less discerning, your pattern recognition weakens, and your thymus basically starts to shrivel up and become like a tiny pile of dust in the chest wall. So, but this is why immune support in cancer prevention looks very different from immune activation. And this is where thymus peptides and thymosin alpha 1, when used appropriately, they fit very well. They're not growth signals and they don't stimulate proliferation. They support T cell education, natural killer cell recognition, dendritic cell functions. In other words, they help the immune system remember how to supervise. And it's like they went through leadership re-education. And that's where they are appropriate when they fit into premalignant states, especially early intervention, remission. They align with prevention, not pressure. So when surveillance is restored, when the immune supervision improves, abnormal cells are cleared earlier. Adaptive clones lose their advantage and tissue starts to regain stability. So this doesn't require aggression, it requires clarity. And clarity depends on the environment that we've actually created. So that's why immune surveillance is the third leg of this and final pillar of cancer prevention and recovery. So in the full framework, when we pull it together, cancer emerges when cells lose identity, your membrane signaling fails. And they lose metabolic purpose and you have mitochondrial dysfunction, and cells lose supervision so that you have a breakdown of immune surveillance. So none of these are isolated events and none of them are caused by genetics. This is all environment and they reinforce each other. So, once one starts to go, then the other two start to follow in line. And they're all shaped by the terrain in which they live in. When we address all three, we are no longer just reacting to the disease. We're restoring the conditions that make health possible. So cancer doesn't begin when a tumor appears. It begins when systems normally correct error stop doing their job. And our work is to help those systems to remember correctly. So the big question is, well, what can we do about it, right? What can we do about the terrain? So now that, this is the part that, we're always very careful with because, improving terrain is not about generating panic or fear or that kind of stuff. It's about awareness, correction, and timing. And your terrain is not destiny, just like your genes aren't destiny. So one of the most important things to understand is this: having a permissive terrain does not mean you have cancer, right? It does not mean that you will get cancer. It just means that the opportunity exists. And so I like the analogy: if you leave your keys in the ignition in your car with the window down, your car if somebody's in the area and wants to steal a car, your car becomes the easiest one to steal, right? But it doesn't mean that if you leave your keys in the car with the windows down that it will get stolen. It's just the probability goes up, and the longer it stays like that, the higher the probability gets, right? Like if you do it one day and you're like, oh gosh, that's it's silly me. I left my keys in the ignition and the windows down. There's a good probability that it's not going to get taken. But if you have that pattern where every day you come home and you leave the keys in the ignition and somebody notices, then it just makes it easier to take advantage of that situation. And that's essentially what cancer does. It takes advantage of a situation. Now, cancers have prodromes, and they don't appear out of nowhere. Like I said, you're not walking down the street and then you get struck by the cancer lightning bolt. Across different tissue types, we see predictable biological patterns that emerge before cancer takes hold. And these patterns involve membrane composition, lipid signaling, oxidative balance, metabolic efficiency, immune context. We call these patterns prodromes, and they're not diagnoses. They are more like what we call early warning signals. And so I use a tool that I use is called the prodrome scan, and this is from prodrome.com. This is not a cancer test. It does not tell you if you have cancer, but it does give you insight into what your membranes look like and how resilient your lipid signaling is and whether the terrain is protective or permissive, because your membranes are where identity begins. And long before tumors form or membranes change, you can see that in this prodrome scan. So every cancer type has a characteristic membrane and metabolic pattern that shows up basically years in advance. It's very rare for something to happen all of a sudden. Your awareness of it is all of a sudden, but that doesn't mean that the occurrence of it was all of a sudden. It took years to brew and grow and create that environment. And to be clear, if you see a permissive pattern, it doesn't mean that disease is inevitable. It means we need to get you off that path, right? Like we need to remind you to take the keys out of the ignition and lock up your car, and maybe put one of those things on the steering wheel. It's a good deterrent, because once you create a terrain that is prohibitive, then it would be very hard to impossible for cancer to take hold in that scenario. So it empowers us to do something. And it means, again, that we can close the car and take the key out of the ignition. That's what this helps us to do. So once we understand someone's terrain, interventions become much more logical. And instead of guessing or reacting, we can be more strategic. And everything we do falls into one of the three categories of prevention, action support, or remission and recovery. So the goal is always the same. We want to restore the identity, restore metabolic purpose, and restore supervision. So that's basically how we look at this. In prevention and premalignant states, like the client with gastric metaplasia, the goal is stability, not stress. So this often includes targeted supplementation to support membrane repair, reduce lipid oxidation, improve mitochondrial efficiency, and support immune recognition. These aren't growth signals. They're not maintenance signals. Some of the common supplements that we would use, and this is just a partial list of things that we commonly use. I'm not suggesting that you take these, but a B complex and a B complex, the B vitamins, very, very powerful. You need way more than you think you need, and you take in way less than you think you take in. So B complex, at least 100 milligrams. Now Foods has a great B100 complex where you get 100 milligrams of the different B vitamins, and that's what you want. Acetyl L-carnitine helps fatty acids into the cell, into the mitochondria, so the mitochondria doesn't get dysfunctional in the first place, right? So carnitine is an amino acid, and amino acids need to be broken down in stomach acid. So if you're chronically on PPIs or antacids or taking things that reduce stomach acid, then you're going to have trouble breaking down food protein into amino acids. And if you don't have enough amino acids, such as carnitine, then you can't get fatty acids into the mitochondria. So it's all of the body is very orchestrated. It's very complex. It's definitely not something you want to micromanage or deal with. The body knows what to do. It knows how to heal itself. It's just sometimes it's missing the resources that it needs. And that's why this is the supplement pack that we start with to meet some of the core basic requirements. Creatine is another supplement that we use quite frequently. The brain and the muscle need creatine. And it takes a huge load off of energetic systems in the body that have to create creatine from scratch. Then N-acetylcysteine also helps with glutathione because it's a precursor to glutathione, and that helps detoxify the body and takes a load off the body so that it doesn't have to generate it. Then trace minerals, vitamin C with zinc, methyl B9, B12, though you have to be careful with that because it depends on your status. This is also from prodrome.com, but the BDMC is a type of curcuminoid that's a potently anti-inflammatory and helps. There's tons of things that it does that way out of the scope of this webinar. But if you're going to take curcumin, you want to take the BDMC. No, there's nothing else that's comparable to it on the market. And in some cases, low-dose peptides support immune education or tissue repair may be appropriate. And I hear a lot of, I get this a lot. Well, can peptides cause cancer? Somebody told me not to take peptides, blah, 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 all this. But peptides don't cause cancer in the same way that amino acids don't cause cancer, right? Peptides are simply short-chain amino acids. They're the same signaling molecules that your body uses every day to coordinate repair, communication, and immune function. So cancer doesn't arise because the body has too many signaling tools. It arises because the signaling becomes chaotic, unregulated, or completely out of context. And that's an important distinction. So saying peptides causes cancer is like saying protein causes cancer or oxygen causes fire. Well, okay, context matters. And what can increase the risk is applying growth signals in an environment that is already unstable. So this is why timing, dosing, and purpose matter, right? So peptides used thoughtfully will support regulation, improve signaling fidelity, and aid tissue repair. They don't create cancer. But like any biological signal, using too much, too aggressively, or in the wrong phase can stress rather than stabilize. So again, the focus needs to be on normalization and not stimulation. That's why you want to work with somebody who understands what peptides are doing in the body and what's going on with your body. So cancer exploits dysregulation, not support. It thrives when systems are confused, inflamed, and unsupervised. Peptides that we use in prevention and remission are chosen specifically because they normalize rather than stimulate. They support supervision rather than growth, and they improve repair without forcing proliferation. So it's not about pushing biology, it's about restoring balance. So peptides don't cause cancer, chaos causes cancer. And then IV therapy. So IV therapy is often misunderstood. This is something that we do use. It's not about attacking cancer indiscriminately. You're not using IV therapy instead of chemotherapy. It's about influencing the terrain, the timing, and cellular resilience. So the same IV can be supportive in one phase and inappropriate in another phase, right? So the most in question here is not what we use, it's when we use it and why. And so I want to clearly separate the IVs into three phases of prevention and premalignant, active, and remission recovery, right? Because each, treating those phases as the same would be the wrong strategy to do. So in prevention, the goal is stability, right? We're not trying to stress out cells. We're not trying to repair membranes. We are trying to repair membranes and reduce oxidative noise, support mitochondrial confidence, and improve immune supervision. The different types of IVs that we would use in preventative type goals here would be phosphatidylcholine. So remember the cell membrane, the house of the cell membrane is made up of phosphatidylcholine, right? So that is phosphatidylcholine supports membrane repair and signaling fidelity. And that's actually the first strip that we use in non-cancer patients too, because it's so powerful and so many people have membrane signaling problems. and phosphatidylcholine is the ideal IV for membrane repair. This is identity support, right? Not growth stimulation. It improves the cell membrane. We also use something called regenerative protein arrays, and they provide structural repair signals. So they're contextual, they're not proliferative, they don't grow things. You think of them as like guidance cues instead of gas pedals. Then we use a lipoic acid mineral complex, and that helps support mitochondrial enzyme function. Glutathione buffers oxidative stress and helps prevent the chaos. And you can use methylene blue. There's certain times you don't want to use methylene blue, but in prevention, our goal is really to help the cells to stay confident, regulated, and specialized. So in active cancer, when cancer is active, the strategy changes, right? Here, selective stress can be appropriate, but only when the tumor biology supports it. So you have to know what kind of cancer you're dealing with. So if iron availability is known, the tumor biology supports it, then the patient can tolerate a lot of oxidative stress. You can think about something like artesunate, right? Artesunate exploits ferroptotic vulnerability. So, that's if the iron is high, artesunate can be a useful type of IV in this phase. Now, it's not something you use preventatively, and it's not something you use in remission. It's something you use strategically in conjunction with an oncologist. High dose vitamin C. So vitamin C can act as a pro-oxidant in tumor tissue. So a lot of times in between chemo sessions, high dose vitamin C can be given. And that's also context dependent and not preventative. It's not something that we generally do in a preventative factor. And high dose, I mean 50 to 100 grams of vitamin C. So, getting a vitamin C infusion that's 5 to 15 grams is refreshing, and it can be, helpful. It's not really preventing much, but at 50 grams to 100 grams, you're working in active cancer therapies. So these therapies aren't for everyone, and they're not for every phase, but active cancer requires precision and not necessarily enthusiasm. And then remission is where the terrain works matters the most. So the tumor's gone, but the environment may still favor adaptation, and this is where recurrence risk is shaped. So in remission IV therapy, the goal is to return to a stabilizing role. So again, we're bringing phosphatidylcholine back in, glutathione, alpha lipoic acid, targeted nutrient replacement. Mistletoe is another drip that is commonly used, and that works through immune modulation and helping to with inflammatory signaling. It's not a toxin; it's more of a communication therapy. So those are some common treatments that we use for cancer patients in all of the different stages. So IV therapy itself is not what we consider a cancer treatment. It is a terrain shaping tool, and used correctly, it can support identity, restore metabolic purpose, and improve supervision. And used incorrectly, it can add stress, noise, and accelerate adaptation in the way that it's already. So bringing it back to our 61-year-old with gastric metaplasia, the focus is not aggression, it's prevention. So we're not trying to kill anything. So we started him on a supplement protocol with a combination of peptides, lipid replacement therapy, supplements, and dietary changes, because omega-6 is a big contender in all of this. He didn't want to do injectable peptides or IV therapy. It was enough that, he came to us from conventional medicine, but we're working on him. But everyone's risk tolerance is different, right? And everyone's treatment plan is going to be different as well, which is why there isn't a standard list of things that everyone should do. It's all very individual, and which is, I know everybody wants just tell me what I need to do, but I don't know, because I need to know what your biology looks like, what stage you're in. There's so many factors that go into individualizing somebody's treatment plan. So that's really important. And it starts with lab testing, doing a prodrome scan to look at the lipid the lipid biology and running from there. So, and that's why terrain-based care is very individualized. It's the same tools, different timing, different intent, and understanding where your terrain is first is really important. And improving terrain is not about chasing cancer. It's about restoring biological conditions where cancer can't occur. And cancer doesn't appear because the body wants it. It appears because the body's run out of better options. So in this webinar, we've raised questions about your own health, or if you, help to see how cancer risk differently. The next step is not fear, it's clarity. So we do invite you to schedule a discovery session with us that would be with me specifically. And, we can start talking about what your terrain looks like that will allow us to be proactive instead of reactive. Our goal is not to diagnose disease, but to assess risk, resilience, and opportunity. And, health isn't the absence of disease. Health is so much more than that. And that's the path that we're going down and we're discovering, because once you get the body back in alignment with where it needs to be, then, the question is, there's bigger longevity questions that you can ask. But first you have to get to that baseline, where you're out of the at-risk or, high risk categories, because the body only works one way, right? With everybody. It doesn't matter what color, sex, age, ethnicity, it doesn't matter. The body at the biochemical cellular level works the same in everybody, right? So when you deviate from that, what happens is you manifest different disease states, right? And cancer is just one, right? There's autoimmune conditions, there's mast cell conditions, there's all kinds of things, immune flare-ups, so many things can occur. There's like millions of diseases, right? Millions of ways of manifesting deviation from that one health, that one path, and where the body functions, at a high level. And, the question always is, if the tissue gets all the nutrients and all the things that it needs on an ongoing basis, would aging then exist? And that's a question for a whole nother webinar that we will explore at some point. But, for now, you can, like I said, schedule a call with me at gophillywellnesscenter.com/consultations. You can scan the QR code that is up there now. You can visit our website and just learn more about some of the stuff we do. And I certainly invite you to watch some of our videos on YouTube. We got lots of them. And a lot of them, they're talking about cell membrane and mitochondria, because it's a big, beefy topic. But the core of cancer is coming back to dysfunctions in these two main areas, and we have to keep them healthy so we don't have a permissive environment for cancer. All right, everybody, thank you for joining me tonight. Really appreciate it. And I look forward to the next time that we have a webinar.